Thank you so much. My pleasure. My pleasure. I love this topic. This is the new frontier. I saw your one of your reps was here talking about my first the PSMA imaging. Well, we only have PET scanners at one, which is in Mesa. Mesa. We have scanners there.
The mystery around is great.
Oh, is it?
I didn't even know you were part of the group, but I just happened to do some like online study.
Oh.
It's good time.
Yeah. All the scheduling is done over the phone right now. I will bring that up with our manager.
Yeah.
I wasn't aware that there was a hurdle that I was scheduling. I'm definitely bring that up.
And for the
They are, yes, and I'm going to get into that because really the National Cancer Center guidelines now basically say this is front line for a lot of these things. The amyloid, I'm going to present amyloid imaging as well. That's still developing for diagnosis of and for MCI, so there are indications for that. Specifically, patients candidate for treatment. Now that's why the FDA approved it essentially, because now before when there wasn't treatment for Alzheimer's, is what difference does it make? Now, if you have a positive, it's one of the criteria for actually giving the treatment. So and then, so all of these things. Oh, I get those every so often. I get this like blood work is off, and oh. Yeah. So full body screening, that was like 5 years ago. There was talks about full body MRIs. Full body. People are still talking about, but I think I would go with the MRI angle. No radiation. I wouldn't expose myself to full body radiation when I could get an MRI. So I've not heard about that for just a healthy person. Otherwise, full body scan, no radiation, and you see the organs. Because there's certainly many cancers that don't really light up on it. I'd rather have the MRI. To be honest with you, like renal cells, like indolent renal cells, they don't get hot. Liver cancers, we don't we no, the hypo, because it all depends on the metabolic rate of the tumor. So if the metabolic rate is low, it doesn't light up. Or if it has like a large cystic component, like cancer, there's not enough solid tissue to light up. So definitely there's hurdles. Colon cancer, for example. We have a lot of bowel activity in the colon. So I can't tell if that's cancer. Sometimes if you have very little bowel activity and then I see one nodule, then I say get a colonoscopy. But if there's a lot of bowel activity, I can't see nodule. So I'm going to last on the PET, new tracers, new tracer for renal cells, new tracer for tau proteins, brain, Parkinson's, new tracer, and I just
I don't like that. I don't like that red sweater lady. She's like, the lady with the red sweater. I don't really feel like. I don't like her, to be honest. She's one of those tough ones. No, I just don't like. She's like 60 years old and she calls everyone baby. It basically her babies compared to her. No, but like it's like not. Like why the fuck? I don't even know you. Like I don't feel comfortable with that shit.
Then you do a PET scan, see if there's residual. If there's residual, you get targeted radiotherapy with the agent.
Bro, this guy's name is.
That's the new frontier. Right now, we're
Bro,
treating,
this guy's so annoying.
Okay, go back to your seat.
Fuck you, no.
we're treating some,
Unless you want to monitor the whole time for me.
So this is like a early frontier.
Wait, Papa. All stars in this screen time.
I was neuro trained. This is MRI therapy. Now 70. I generate the yes. I do about 25% neurology, about 75% I've always been pets is increasing, so pets on a front for a while. So all these new tracers, it's really in real life.
You can talk to your dad like that?
You should come here, please.
Oh, sorry?
You should come here, please.
Oh, yeah. Sure.
I take the chef spoon for you.
Thank you. Yes, let me eat with my fingers. Yeah, me and him would sucker punch me into it. He goes and yells at his dad. He's like, no, it's like, you can talk no, like we spar every day. I would get drop kicked. No, like we spar like basically every day. He like, I would just flat out. Nah, your dad is weird. Your dad is. Oh, like me and him spar every day. Thank you.
They have soda.
Soda taste
Soda?
Soda.
Oh, soda.
I don't like soda.
Ginger ale is fine. Hot water is done.
Okay, ginger ale is nice. But
Where's the apples?
I don't like Coca-Cola or Pepsi or Sprite or Dr. Pepper or Fanta or any of those.
Sprite?
I don't like Sprite.
Alright, hello everyone.
I just don't. Oh my god,
Alright,
it's
so
so
try to
British.
give you enough time. We are going to start our next class, the lunch talk. Presented by
Oh my god,
Dr.
I
Eubig
don't like
from mainstream radiology. While you are getting your food, just do your best.
Dude, if they have the same meal as last time, I'm gonna.
Stay quiet, alright? Alright, so can you hear me? Hello? Better? Yes. Okay. Alright, so we're going to start the first lunch talk, which is about the CAP scan, presented by Dr. Eubig from mainstream radiology. Alright, thank you.
Thank you. Thank you for that warm welcome. Okay, everybody hear me? All right, so I'd like to cover this exciting topic of advanced imaging. We have a number of novel radio tracers, which is actually shown here in your hallway, that have really we've really seen a huge resurgence in PET imaging, and I'll explain all the ways in which we've done so. So I have no disclosures on this matter. So we're going to keep this moving at a decent rate because I want to cover 4 novel radio tracers that you guys might find very interesting. So first one will be PSMA binders, prostate cancer. We're going to talk about estrogen receptor binders for breast cancer. Somatostatin receptor binders. Okay, I'll just hold this. How about now? Better? Okay, I'll just hold this. So estrogen receptor binders for breast cancer, PSMA, somatostatin receptor binders for neuroendocrine tumors, and amyloid binding agents for mild cognitive impairment and Alzheimer's disease. So we're going to break this up like this. We're going to start with prostate cancer. So in 2020, 191,000 estimated new cases. And the thing is that 30 to 50% of these patients demonstrate recurrence even after definitive localized or therapy for localized or regional disease. So a subset of these patients can be rendered disease-free if their disease is caught early enough and well diagnosed. However, the salvage radiotherapy after radical prostatectomy is poor, ranging from 10 to 40% due to the lack of accurate imaging modalities. And this is exemplified in this Kaplan-Meier analysis. So here we see time from radiotherapy and proportion of patients with free of disease progression. So you can see as time increases, the proportion decreases. But if we break this up by PSA levels, we're really targeting this top blue line. We're targeting those patients that had low PSA levels. Like patients with low PSA levels likely had very localized disease, and these patients do well. These patients in red, for example, had the salvage therapy, but they probably shouldn't have had that type of therapy because we missed a number of metastases in these patients due to lack of adequate imaging. So really, as I highlight here in red, the current unmet need was to find an accurate diagnostic examination that could localize prostate cells and prostate cancer cells in patients with biochemical failure. So that all changed when in 2020 the FDA approved PSMA PET-CT. So what is PSMA? So PSMA is a type 2 transmembrane protein, and it's expressed on the apical side of prostate ducts and is upregulated in prostate cancer. It's associated with prostate cancer aggressiveness, so it can have a prognostic relevance. They have both renal and hepatic excretion, and it really binds with high affinity to our agent, and it's internalized by prostate cancer. So what are the different options right now in the market? Well, we have 3 on our formulary, and they're called Pylarify, Plasma, and Illuccix. And they all have their risks. They all have their benefits and drawbacks. But overall, research has shown that performance is more or less similar. But just to kind of break it down, the big difference is that some are bound to GA68 and some are bound to F18. So that's a difference because GA68 is produced in a generator and F18 is produced in a cyclotron. So theoretically, distribution may be different as you can produce larger batches in the cyclotron than in a generator. Also, the energy of the positrons is different, so theoretically the resolution may be different. However, we're also learning, research is showing that GA68 has less binding to bone, so there's better resolution when it comes to bony metastases. So while Plasma, for example, has better renal clearance, so it might be better visualization of the prostatectomy bed. So each of them has their advantages and drawbacks, and if you're thinking about which one to order, you can always call us up. I'd be happy to answer any questions. PSA performance is highly dependent on PSA levels, and that's exemplified in this study where patients with very low PSA levels, the proportion of correctly diagnosed is lower than patients with levels over 10. Then we're pretty much always seeing metastatic disease. So I'm just going to show a few images, how powerful this study is and its utility. This is a study I recently saw. This is a full body MIP image. This little dot here is actually a little piece of normal colon, so don't worry about that. This is the solitary finding in this patient. It's this one little left pelvic side wall metastasis here. So this patient post-radical prostatectomy, rising PSA level. Surely this tiny little node would not be diagnosed on a CT, conventional CT image. It just doesn't meet size criteria. Although here, this patient has a metastasis. Similarly, I have just the same day, another powerful case here. So we see that I have 2 images, 2 different levels, and one little metastasis in the left retroperitoneum and one here in the left pelvic sidewall. So this patient only had 2 metastases. Again, would not have been diagnosed on conventional imaging. You guys may remember we used to do a study called Axumin. That was an amino acid that we used for prostate cancer diagnosis. So actually, this is a slightly older study, but they compared Axumin and PSMA in the same patient, and in the same group of patients. I think there was 50 patients in the study, and you can see that diagnosis 56 with PSMA percent versus 26. For pelvic nodes, 30%, 8%. So vastly improved, and I found an image here. This is the same patient. This patient has all these mets here above and below the diaphragm, none of them visible in Axumin. So really, Axumin, we keep it on the formulary in one case, in case anybody's wondering. There is a very, very small subset of patients where they do not express PSMA receptors, highly aggressive forms of prostate cancer. So if you initially get a high PSA level and you get a PSMA scan, it's completely negative, but you're really still concerned about metastatic disease, sometimes Axumin will show mets where PSMA won't, but the first line will be PSMA. Similarly, bone scan. This is a bone scan, same patient at a PSMA. All these mets that are seen on the bone scan are also seen on the PSMA, and of course, many, many others are seen. The contrast resolution is perfect with PSMA. Very little bony uptake. I can count many more mets here. And in addition to that, highlighted in red, we see our lymph node metastases, which you'll never see on a bone scan. So again, proves that bone scan is kind of outdated now for prostate cancer. So I wanted to bring up the 2021 updated NCCN guidelines. So I draw your attention to J, this footnote J, and it says here very clearly that due to increased sensitivity and specificity of PSMA PET tracers for detecting micrometastatic disease compared to conventional imaging, which is CT or MRI, the panel does not feel that conventional imaging is a necessary prerequisite for PSMA PET, and that is equally effective, if not more effective, for these patients. So, so different flow charts here, all basically saying the same thing. For radical prostatectomy, PSA persistence, worried about recurrence. You initially had all of these imaging modalities in prior guidelines. This is the Axumin I spoke of, chest CTs, abdominal pelvic CTs, bone scans, all of this being replaced by PET CT. I mean PSMA PET CT specifically. Same thing for radiation therapy, following radiation therapy, worried about recurrence. All these things that were listed before have now been replaced by PSMA PET CT, so it's just a game changer when it comes to staging of prostate cancer. And you asked about initial staging. Well, I'm not a urologist, but I do know, based on this here, that there are different ways of grading initial, based on biopsy, initial prostate cancer initial staging. So one way to group them is into low, intermediate favorable, intermediate unfavorable, high, and then very high groups based on Gleason scores and grade group levels. So this chart here demonstrates that for very low, basically imaging is not indicated. And for intermediate but favorable, you can get away without PSMA imaging. But everything above that, which is unfavorable, intermediate, high, and very high levels, it's PSMA PET imaging would be the first line imaging study. So again, you can see that J footnote under all of these. So just a quick flow chart. How do we look at this now in today's practice? You have initial staging of intermediate to high-risk patients. You have a patient that is staged as that. First line, PSMA PET CT. If it's limited disease to the prostate bed, plus minus pelvic nodes, they get definitive therapy. If there's evidence for biochemical failure, boom, they come right back up to PSMA PET CT. For patients for multifocal disease, patients, next question is, are you considering PSMA-directed therapy, and that would be the current therapy on the market, Pluvicto, which is lutetium-bound PSMA. If you are considering that, then you get PSMA imaging, specifically gallium-68 PSMA imaging, and then if that's positive, then the patient can have PSMA-directed therapy performed. And if there's progression, you come back up and you can reevaluate. So an integral part of this entire flow chart, as you can see, is PSMA PET-CT. One thing to note is that there are a number of conditions that can offer false positives. They're rare. I mean, I've read a number of these by now, but they're divided into bone-related conditions such as Paget's or fracture, inflammatory, and some benign and malignant neoplasms. Again, very rare, but there can be PSMA expression on some of these things. So why do I bring this up? When you order the PSMA, any information helps. That's why I bring that up. So what would we like to know? We'd like to know the PSA level. Any history of any other malignancy would be helpful. Any history of trauma, particularly to the ribs, and the type of therapy the patient has had. Also, this is very important, if considering hormone therapy, do not start it prior to the PSMA study. Why is that? Again, don't understand all the pathways. However, the basic idea here is that if we have low androgen receptor activity, because in a hormone-naive patient, we have high PSMA expression level. And the converse is true. If I have high androgen receptor activity, I'll have low PSMA expression. So why is that important? Here's a hormone-naive patient. And then here's one that has started ADT, and these are supposed to be spinning, but this is a bit of a grainier image, and it can get even worse than that. So we want our best contrast resolution, therefore we prefer our patients to be hormone naive. So that ends the discussion on PSMA receptor imaging. Let's proceed on to breast cancer. So it's the second most common cause of cancer-related deaths, and in recent years, improvement there's been improved survival because of the evolution of biomarker-specific therapeutics. So approximately 75% of breast cancers are estrogen receptor positive, and this is where this imaging modality really comes into play, because the biomarker status is classically established by biopsy. But there's a problem with that, because biopsies, you may miss parts of the tumor in a biopsy. And then also, there's a high variability of ER expression in tumors in the same patient. So for example, in the breast, you may have ER expression in the primary tumor, but in metastasis, you may not. And it's impossible to biopsy every single metastasis in a patient with multiple metastases. So that's what we call tumor heterogeneity. And that's thought to be a driver of resistance in patients with ER-positive breast cancers. So this PET-CT tracer called the Seriana was developed exactly to help us with this. And it's an adjunct following biopsy resection. And what it does is it can assess the whole body estrogen receptor status. So because 10.9% of patients show ER receptor status discordance between varying sites. And also, interestingly, in a third of patients, their ER receptor status can change over time. So 6 months later, they may no longer be expressing those ER receptors, and the therapy needs to change. So what it does, it gives us the ability to predict therapeutic response in distant lesions. So no patient prep is necessary for this, as it wasn't for the PSMA. We want to administer Seriana prior to starting systemic endocrine therapies that block estrogen receptors. And we assess from the skull vertex to the knees. It's actually not taken up by normal brain, like you see with FTG. We can even assess for brain mets. The performance is excellent. It has 95% sensitivity and 95% specificity. And let me show a few cases now to show you how
They didn't give us anything.
crucial it can be for patient treatment. So this is a 67-year-old female with invasive lobular cancer, not responding to estrogen therapy 6 months after diagnosis. So here on the right, this is her FTG scan, and the arrows are depicting several pelvic mets. This is her Seriana scan showing activity at these sites. So at this time of diagnosis, these sites had estrogen positivity, estrogen receptor positivity, and would respond to therapy. Now, 6 months later, we still have hypermetabolic active mets in the pelvis. Observe how on current estrogen imaging, they are no longer hot. So this means that 6 months later, these mets are still active, but not expressing estrogen receptors. So that's why the patient is not responding to therapy. Here's an example of two patients, one that would respond to estrogen, to hormone therapy, and one that would not. So here's our baseline FDG. Look at, for example, look at this axillary region. Look at that clump of malignancy right there. It's on baseline FDS. This is hot. So estrogen receptors are there for targeting. And 8 weeks later, total response to therapy. And this is an example of a patient with diffuse metastatic disease. On baseline FES, we only have a few lesions. So again, this is also exemplifying the discordance in the same patient. Most of these bony mets are not even hot on the FES, except for a few thoracic nodules. But this patient overall had a poor response to therapy. This is also a great reason to use Seriana. Let's say that your only met in a patient is in the spine. And let's say that location right here is C6, right there. Or another location, thoracic spine. So these are lesions that you want to know what their receptor status is. You want to know if you can treat it with hormonal therapy, but it's very difficult to biopsy these sites. Well, this exam will be able to tell you that these are estrogen receptor positive sites and can be targeted with hormone therapy. Similarly, the brain. Let's say your only met is to the brain. Well, the brain takes up very little Seriana, and this thalamic met on the left, and then we have also one here posteriorly in the right occipital lobe. These are estrogen receptor positive and will respond to therapy. This is an interesting case. This is her baseline FEG PET. And look at all, there is heterogeneity here to the bone, but it's very hypometabolic. So this is a low metabolic rate tumor. However, that tumor is positive for estrogen receptors and will respond to estrogen therapy, although probably given its low metabolic rate, it might take longer administration to see a good response. And also, it can be used as a problem solver. This patient had this post-left mastectomy, had this CAT scan, and this is a very unusual appearing lesion with this irregularity and such. I mean, well, I think on the initial scans, this was read as pneumonia, and but it was not resolving with therapy. Well, then a Seriana scan was performed, and there was suspicion. I guess the patient was not a candidate for a biopsy of this, and this turned out to be a metastasis, estrogen positive metastasis. So, in conclusion to this section, the utility here is it can discriminate between ER positive and ER negative tumors, and it's almost like the equivalent of a whole body biopsy for a patient in recurrent disease. They can overcome issues with tissue sampling error, And as I spoke about, there are 4 clinical scenarios you may want to think about this scan. To look for the heterogeneity, the discordance basically of lesions within a single patient. So you can get a guide to which lesions will be targeted by estrogen therapy and which lesions may need to be irradiated in a patient. It can assess ER status in low metabolic rate cancer. It can assess lesions that are difficult to biopsy and can be a useful tool for clinical validation. All right, changing gears a little bit away from cancer for a moment, let's talk about amyloid imaging. This is our most novel radio tracer that we've been doing for about, I would say, 6 months now. Just keep trying on the time here. All right, so a little bit of background. So we all know that Alzheimer's disease is defined by pathological accumulation of plaques and tangles, and basically now we can quantify that using PET imaging. So initially, the first compound that was developed was this Pittsburgh compound, and it was analogous to a dye that was used to label amyloid in postmortem patients. So that compound was adapted, and now we have several amyloid binding compounds on the market. So who do we use this for? We use this in patients with objectively confirmed cognitive impairment, either MCI or dementia, but in whom the cause is uncertain after comprehensive evaluation. Also, patients that may benefit from but the management may change. For example, patients who are candidates for this novel beta amyloid therapy that's out on the market, they will be candidates for amyloid PET imaging. And sometimes if you want to differentiate patients who have progressive or unexplained MCI from those with AD but atypical course, so those would be useful. So again, no patient prep is necessary here. We don't adjust the dose based on age, and we acquire 20-minute PET images in this patient. So how do we interpret this? For those of you looking at the images, you may be curious what exactly we're looking at here. So all these tracers will bind to white matter. What the trick is to see how much is binding to gray matter. Really, there should be almost nothing binding to gray matter or much less than white matter. And that's what we're looking for. We're looking for binding that's restricted to white matter and a preserved gray-white matter differentiation. So on a positive scan, the binding to the cortical gray matter is equal to or greater than the binding to the white matter. And we use visual interpretations. We don't use SUV values. We basically interpret it based on what we see. So some of these agents are recommended to be evaluated with color scale and some with grayscale. The one we use at Main Street is for beta band, and that's the first one there. It's called Neuroset. And it's our images are grayscale. And we look at 4 regions: lateral temporal lobes, the frontal lobes, the posterior cingulate region, and the parietal lobes. And here we have a normal scan, and as you can see, the gray-white matter differentiation is preserved. And I'll get into a few more better images in a moment. And then this is a grossly abnormal scan. You just see this totally white brain. So that means that we have binding to cortical gray matter, which is abnormal. We do a grading of this, but ultimately what you need to know is that if a negative scan basically has to have almost no binding to the cortex at all, totally preserved gray-white differentiation. If I see anything that's positive, even in one area of the brain, it becomes a positive scan. So that is the real differentiation. And although you can break up positivity into baffle score 2 and 3, but for all intents and purposes, it's binary, either negative or positive. So I just want to show you those 4 regions and what to look for. So we look at the frontal lobes. We should see spiculated white matter. It's bumpy, lumpy, bumpy stuff. However, if we see a plump, smooth appearance in the frontal lobes, positive. So if I just saw that, it would already be a positive scan. And we'll also look at the lateral parietal lobes. I should see lumpy, bumpy, spiculated appearance. If it's plump and smooth like this, positive. Also in this slice, I can see that this box has been thinned by this positive gray matter adjacent to it. We also look at the lateral temporal lobes, and again, it should be kind of mountainous looking, like this. Here it's blown out and smooth. And I also look at the posterior cingulate gyrus. We call this the donut sign. If I see a nice hole here, that's negative. If it's filled in, positive. So this is an important point here. I have in boldface. A considerable percentage of cognitively unimpaired older subjects will be positive. So just having a positive amyloid scan does not convey a diagnosis of Alzheimer's disease. And I know I have only a minute left, so I'm just going to quickly go through neuroendocrine tumors. And they are a rare heterogeneous group of tumors that express somatostatin receptors. And what we have now is dotatate imaging. This is where you guys would be ordering octrio scans before. This is an octrio scan. This is the equivalent dotatate image. Notice the improved contrast resolution showing these lesions. This is an octrio scan on a patient with diffuse metastatic neuroendocrine tumor. This is the equivalent dotatate scan. So much improved specificity, sensitivity, negative predictive value. These lymph nodes, metastatic neuroendocrine tumor, these would not be diagnosed on a conventional CT image because they're too small, they don't meet CT criteria. But now it's showing positivity. A small tumor in the distal ileum would not be seen on a conventional CT scan. However, now we know where our primary neuroendocrine tumor lies in this patient. And this is a case I just wanted to show real quick. I added this last minute, this case from yesterday. This is the first I've ever seen this. This patient had this tumor here, neuroendocrine. This was obvious on the CT scan, but there was a concern for metastatic disease and staging. And this entire liver was negative on contrast enhanced CAT scan. No lesions seen at all. And look at this liver here on dotatate scan. So metastatic treatment changes. So, and this can also, for our neurosurgeons here in the audience, meningiomas also take up dotatate because they do express some metastatic receptors. So this can be used to look at the margins of a meningioma and for improved resection. So, and I just want to say that on the horizon in Main Street, we have things that are waiting FDA approval that we will be getting. We're excited about this new renal cell agent that's going to be used to diagnose renal cell cancer, which is notoriously poor when it comes to FDG uptake. F-DOPA for Parkinson's disease, and Tauvid, which would be for neurofibrillary tangles and tau proteins. So all things to watch out for. So thank you for your attention, and have a good day.